Look at these two x-rays. Look at the first x-ray. The first patient is admitted to the ICU for 3 days. We can see various tubes and lines over the chest of the patient. There is also presence of endotracheal tube. On attending around in the ICU, you find that there is unexpected increase in dyspnea and the breath sounds in the chest are diminished. You are suspecting pneumothorax and you request for a chest X-ray. Now look at the second X-ray. The patient presented with trauma to her chest and abdomen and has mild dyspnea, and you are shown this X-ray. Which of these patients have pneumothorax? If you have no idea or think neither of the patients have pneumothorax or only one of them does, then this video is for you. Welcome to Radio Clinics, and the topic for this video is how not to miss pneumothorax. Coming to the introduction of pneumothorax, pneumothorax is the presence of air in the pleural cavity. There may be no symptoms at all in small pneumothorax, but symptoms like dyspnea, chest pain usually occur in many patients, and some of them with massive pneumothorax may have symptoms of hypertension and subsequent tachycardia due to air pushing upon the heart and mediastinum. It may be of two types: spontaneous, when there is no any antecedent cause, when there is some underlying disease like air-filled bulla or blebs which may rupture into the pleura and cause pneumothorax, then this is called secondary spontaneous pneumothorax. Otherwise, vast majority of the pneumothorax we see are usually from trauma, when fractured ribs may indent and tear the visceral pleura, or iatrogenic, from lung biopsies and FNACs, when air may leak from the lungs into the pleura. The features of pneumothorax are presence of lucent area in the thorax which is devoid of bronchovascular markings. These represent the bronchi and vessels passing into the lungs, and when there is air in the pleural cavity, these markings will be absent. Like in this case, we can see that the bronchovascular markings are present in the lungs, but here in pneumothorax we don't see any bronchovascular markings. Similarly, in the left side also we don't see bronchovascular markings in the peripheral aspect, while bronchovascular markings can be clearly seen in the central region of the chest. Next is the appreciation of visceral pleural line. This line separates the pleural cavity from the lungs. So this is the visceral pleural line. In normal lungs there is small pleural space which contains normal pleural fluid, so the pleural line will not be visible. But in pneumothorax, the pleural space will be filled with air and the visceral pleural line will be separately visible within the thorax. Air in the pleural cavity may also push the lungs and cause collapse of the lungs. So here you can see that air in the right pleural cavity has pushed the lungs medially, and the whole of the right lung appears as a opacity near the mediastinum. Collapsed lung will appear opaque. So the three main features of pneumothorax are presence of lucent area in the chest which are devoid of bronchovascular markings, presence of visceral pleural line, and in most cases we can also see that there is collapse of the lungs. What about the supine patient? In wards and ICU and in the emergency room, when the patient can't be erect, X-ray is taken with the patient in supine position. In supine patients, the diagnosis of pneumothorax is somewhat different. In such cases, the air accumulates anterior to the lungs. In the first diagram, I have shown the representation of pneumothorax in a erect patient. Air is accumulating in the periphery of the lungs. But in the second patient who is in supine position, air goes anteriorly because it is lighter than the lungs. So we may not be able to appreciate the typical peripheral visceral pleural line, peripheral lucency in the lungs. And because of the presence of air anteriorly, the lung will appear hyperlucent than the opposite side, because air provides for excess lucency. Since air is present anteriorly, it will push the diaphragm more inferiorly. So the diaphragm and especially the costophrenic angles will appear deep, and this is called the deep sulcus sign. Now look at this X-ray. In this X-ray we can see that the left lung is more hyperlucent than the right side, and we can see that the costophrenic angle in the left side is shifted downwards and looks deep. This is called the deep sulcus sign. and this is the feature of supine pneumothorax. Next sign that we may see is called the double diaphragm sign in a supine pneumothorax. In an erect patient, we will be able to see only a single dome of diaphragm, but when there is presence of pneumothorax, the air will outline the dome as well as the anterior margin of the diaphragm. So we can see the two diaphragms, and this is known as the double diaphragm sign, and this is also a sign of supine pneumothorax. Coming to our query, in the first X-ray, who is a patient in the ICU with acutely increased dyspnea, we can appreciate that besides the presence of bilateral perihilar consolidations, we can also appreciate that the right-sided sulcus is quite deep and the right lung appears hyperlucent than the left side. So this is the case of right-sided supine pneumothorax. In the second X-ray of a patient with trauma, we can appreciate that there is presence of lucency in the periphery of the lungs. We can also appreciate the visceral pleural line. So this is the visceral pleural line. So this is the case of bilateral pneumothorax, more towards the left side. So the answer to our query is that both our patients have pneumothorax. The final words for this video are: in an erect patient, for diagnosis of pneumothorax, we should look for peripheral lucency, which is devoid of bronchovascular markings. And in a supine patient, for diagnosis of pneumothorax, we should look for lucent lungs with a deep sulcus. Thank you.